which goes very well. And as my good friend Suresh says, no two acoustics are similar. So you can have a very nice, everything good result in one day, and one day you have a not so big giant tumor, but you can have problems. So I'll share with you some of the problems one can have and some of the solutions to uh, kind of avoid this. And sometimes it happens to do the some preventive measures and treatment. So we'll go one by one as we go for the surgery for during positioning. Now, we know these are the two common positions which are used, the lateral position and the semicylindrical. The lateral position, the problem is large tumor, the brain bulging, it takes much longer time, always there is blood in the field. Semi-sitting position is good because the brain is lax, you don't have to do a ventricular tap, you don't have to take out the foramen magnum, but you need to do a lot of monitoring because there are risks associated with the position. Right? So the commonest and obviously very well-known complication is the air embolism. So one is always aware about it. So we do see,
Basant, there is some echo. I don't know why, but
no,
I
no,
can
no,
hear.
this is the video. This is the video sound. Okay. It's a video sound. It will go away. It is the OR sound. It is recorded in the operation theater. So there is noise inside the operation. So this is, we do TE along with that and along with the other routine. But the critical thing, as you can see here, is the foot should be above the neck level so that the risk of air embolism is reduced. Now, there are obviously advantages. The lax brain, as I said, that the minimum no coagulation, blood drains away, this much faster surgery, and you can do a better and faster plane and better preservation is claimed. But the risk is obviously the air embolism, which is very well known. Air embolism is very common actually. It may not be clinically relevant all the time, but this is very, very common. If you are monitoring with TE, it almost 70-50% of patients will have some degree of air embolism in spite of all your efforts, especially if you have a residency training program and the residents are doing the craniotomy, they can have these risks, which sometimes doesn't affect the patient. But it can sometimes affect, then you have to have the preventive measures. It's difficult in elderly and cardiac dysfunction patient with patent foramen oval. One of the problems with sitting position or semi-sitting position is you have to support the cerebellum because cerebellum falls down because of gravity. You don't need to retract, but you need to support it and need to do this monitoring to pick up the air embolism early on. So one of the prevention, reducing the risk of air embolism, as I said, feet above the neck, you have to have central vein access. And unlike other brain tumor surgery, we do PEEP. And you fill up the blood volume so that patient is not dehydrated, there's not negative, there's air embolism is reduced because the veins are engorged. And of course, you need to have hemostasis right from skin because large veins in the skin, in the bone, all can produce air embolism. So all that, you have to be prepared of that. Now, if it happens, the anesthetist has to be on their toes. They have to be there in the theater all the time, not on the mobile, not chit chatting, but monitored. They have a eye on the monitors. If it does happen, the first thing we do is the two anesthetists are required. One is aspirating the air from the neck veins, the central axis. And the other anesthetist compresses the neck vein, the jugular veins. What it does, it increases the pressure inside the veins, and if the collapsed vein, which has sucked in air, gets engorged, start bleeding, so that the surgeon can see where it is where the air is going in, and then you can coagulate that. So that's critical that both the things should be simultaneously taken care of. And early on, you do that, and there is no risk to the patient. And this is one T. You can see the air there. I don't know, you cannot hear the sound, but this is the air going in there, and that air picking up in the TA is much before any changes that happens to the patient. What is not so well emphasized, I have talked about this many times. This is a disaster patient which I had. This is a lady with a 4-centimeter tumor from Bangladesh actually, I operated, everything went on smoothly. The patient woke up with a paraplegia. We took the patient from the theater. Face was good, but this had a paraplegia. So we took the patient from the theater to the MRI. You can see the diffuse and restriction, which could be either ischemia or more likely infarction. Fortunately for the patient and for us, the patient improved over a period of time. For a couple of months, he became, vision, the power became normal. So probably it was ischemia. So you can understand the scare one can get, both the patient and the surgeon, if you have some kind of disaster when you were not explained about this problem. So if you are doing semi-sitting position, it is better to add on MEP along with that, and be careful about your blood pressure not going down below 100 systolic. We actually did all our cases in the CP angle, foramen magnum, and pineal region, clival. We, from 2012 to 2016, continuously every patient was done in the semi-sitting position, because one of our resident had a vegetation, prospectively analyzing the complications. And since then, because of some of these complications, which is not in the hand of the surgeon, you depend on the anesthetist, monitoring, and so on. So we have moved on. For only giant tumors or tumors in the pineal region or the tumor central clival, we do a semi-sitting. We don't do otherwise semi-sitting. Most of patients CP angle today are operated. Since after 2016, we operate in the lateral position. So that one has to be careful about when you are doing the positioning, and because of the positioning, the problem. During craniotomy, of course, you can have the disasters because the sinus injury, because the vertebral artery injury. Now, the one of the things which I tell the resident, we do a craniotomy like this, but over the sinus, we drill it. We don't do the craniotomy. Especially in patients who are older, the dura is very stuck to the bone. And if you do a craniotomy, you can completely shiver the sinus, which can be sometimes disastrous. Most of the time, a small holes in the sinus, you don't need to panic. You just need to put some gel foam, patty, and leave it there, and that takes care of it. In fact, not a single patient I have had a problem where I had to suture it, or I had to repair it, or put a graft. Some people have described it. It's not necessary unless it's completely severed, and then it's disaster if it is the dominant sinus. The vertebral artery injury is a problem again. If you have a training center, one of the tricks to avoid it, when you are doing the incision lower down, it goes more medial. So the S-sept incision like this comes down like that. If you have to open the foramen magnum, feel the C1 midline and come from there laterally, subperiosteally, and then you don't injure the vertebral artery. One has to remember, when you position, the vertebral artery becomes more medial. So one has to be careful that you feel the C1 posterior arch, the midline, the protuberance there, and then you can come from subperiosteally, and then there is no risk of injury. Now, during tumor removal, the standard, but the important thing which I would like to emphasize is monitoring. I believe very strongly in monitoring. What it does is better preservation of function. It keeps giving you warning when you are close to the facial nerve. The facial nerve monitoring is routine in our practice. The BERA we do when the patient has functional hearing, good hearing. Many times, even if the patient says that he can hear, you do a BERA, and the wave one you cannot elucidate. Then you cannot do the monitoring. Doesn't matter whether the patient hears or not, because you cannot do the monitoring. But the facial nerve monitoring is routine. Now, it makes the preservation better. The quality of function is better. I think it's the standard of care today, and we cannot get away from that. The problem in countries like ours is the failure of systems. So you need to have multiple system alternatives. If one system fails, you can do the other one. The one instrument in my practice is very, very important for all surgeries, not only acoustic, for all vascular tumor surgery, is a calibrated suction. It's worth investing on a good, the tips should not be, kind of damaged, smooth tip, and the calibrated suction goes a long way in very good preservation of function, because I use that instrument for all my dissections, suction, decompression, and so on. The intra-aortic canal drilling, again, is almost routine in my practice. And especially if you would like to have a total or near total excision and good function preservation with less recurrence risk, is better to drill the intra-aortic canal. The key to drilling intra-aortic canal and not damage the nerves is wide drilling. A narrow drilling causes more problem than good. So you want to drill the intra-aortic canal, do a 180-degree drilling. This is from Fukushima's monograph. It's a very nice book. People have it. Please read it, because this is a beautiful, kind of educational book. And I would definitely recommend that the young neurosurgeons have that and read it. So we believe that it helps in total excision, reduces recurrence, is standard of care, 180-degree drilling, and some of the precautions, lot of irrigation, so that you don't produce heat and the heat does not damage the nerves. Calibrated drilling, especially if you're trying to preserve the hearing, 5 to 6 millimeter, not more than that. And the lateral part of the tumor you can take out with an endoscope assistance. Of course, if the patient is deaf, then you can drill right through the lateral extent of the tumor so that you can remove it. I'll just show one video and just give the essential points. This is about less than 3 centimeter tumor. Again, critical that the transverse sinus and sigmoid sinus is seen. This junction is seen. The linear incision of the dura and helps in the watertight closure and leaks are prevented. The first thing I do is this is in lateral position. This is the petrous, posterior petrous coagulation. The blood supply comes from there and staying in that plane, the tumor arachnoid plane, whether you believe in that or not, but there is a glistening layer which is separate from the tumor. And try to separate that glistening layer. Now, if you have any doubt, err on the side of the tumor. Be on the side of the tumor. You can always come back and take the tumor out. Don't err on the side of the glistening membrane. And then, of course, decompression till the tumor becomes, the bulk becomes less. And before we go on to the intraocular canal drilling, and this is dissecting from the this is two-hand dissection, dissecting again, trying to stay in that plane where we are not going beyond that glistening layer, which I'm very careful about why I'm using, because Suresh is there, he will tell you it's not arachnoid, it's a penurium, but whatever it is, what I stay is in that glistening layer, I am away from it. The tumor surgery is all extra arachnoid. It's not in the subarachnoid space, as opposed to the vascular surgery, which is in the subarachnoid space. It's critical not to open the subarachnoid spaces which are patent. Like, for example, the subarachnoid, the arachnoid covering the lower cranial nerve, the carachnoid covering the fifth cranial nerve. We don't need to open it. If it is still covered, that's the best protection for the structures, anatomical structures. And then we drill it. Now you drill first, we coagulate, take out the dural cover there, and then we find out what is the intraocular canal and meatus. We first do with a burr, and the one which I use, the names have changed, but this was the old M8, used to be M8. Now you see the wide drilling there. It's a lot of irrigation, continuously irrigation. One precaution, never have a patty when you are drilling, wherever it is, and not in the field, there should not be any patty. That can be disaster. The drill picks up the patty, and then the whole cerebellum comes out with the patty. So when you are reaching near the last bits of the bone, you do with a diamond drill. And then you cut the dura. The dura is covering that. You cut it with knife, and then we decompress the tumor inside the intraocular canal, especially if there is a lot of tumor there, with a very low strength CUSA, which I use is usually 30 in the system which we have. But whatever you have, just use a very low strength CUSA. And if the tumor is small volume, don't use a CUSA, because you can damage with the CUSA the nerves. And then we use different instruments, the hook, the nerve stimulator, to find out where the tumor is, where the nerve is, and then we dissect the last parts of the tumor are taken out. You don't have to go very laterally if you're trying to preserve hearing. And this part can be taken out with these instruments or with the endoscope assistance. Sometimes we use endoscope assistance, and this I don't think we have used it. Now you see the nerve coming into view there. So I'm trying to preserve and take out the tumor. This is nerve, my dissector nerve stimulator, and this is always giving me a warning where I am, and it's very low strength. This NIMS monitor is 0.08, the parameters I use, and that you see that glistening membrane covering the nerve, and that's my landmark not to go beyond this. And this is the whole tumor has been removed. That's the facial nerve. And then the another thing, which the air cells sometimes are there in intraocular canal. So you need to fix that by always you put a little bit of fat there and you put a glue. And if you're doing especially semi-sitting, fill up with water or saline. And then we primary closure, watertight, and then fat graft, and then stitch the fat graft. So reinforce the incision line with a stitch with the fat. And that actually has reduced significantly the post-operative pseudomeningocele and CSF leak. I'll skip the video, but what I'm going to say that today we do this. This is beautiful. You can see the smaller tumor, very nice nerve And then we do a craniotomy today, and that hopefully reduces the risk of post-operative headache. We fix that. There is no class 1 evidence to suggest that, but this is the practice we do today. And then you can have very good hearing and normal hearing and good facial function. Now, risks to the cranial nerve 7th and 8th, we all know. Just medial to intraocular canal meatus, the mechanical adherence is significant. And what's not so emphasized is, especially in large and giant tumor, is the sharp angle between intracanalicular compartment and the extracanalicular compartment. And there's almost a 90 degrees. So one tends to lose the plane. So one has to be aware of that and take precaution that you don't lose it. At the brainstem end, it's more often the venous injury which produces the flea field becomes flooded with blood, and then you lose it. Now, if you have a vein bleeding, we don't need to coagulate. We just put a gel foam over that, put a little patty, leave it there, go back somewhere else, and that's the best way to not to injure the nerves, not to injure the normal structure, and achieve hemostasis. Inside intraocular meatus and canal, there's an arterial injury, thermal injury because of coagulation and drilling. Avoid that coagulation. Lot of irrigation. And labyrinth injury, avoid going very lateral and use the endoscope assistance. Now, some adjuncts we have found useful, the fluorescein to distinguish between the tumor and the nerve. The tumor enhances, the nerve does not. Sometimes it helps. You can pre-operatively, you can find out where is the displacement like. That's the 7th nerve, that orange one. And so you appropriately, when you near that, you take precautions. And that was the concordance rate between the MRI finding and the surgeon's finding was very high of 85%. Now, what about a young neurosurgeon who is operating in a giant tumor, has a problem? As I told many times, no shame in coming back. These are benign tumor. Have a problem, come out, go back again, or call a colleague, or send it to somebody who has better experience. Because you can always go back and take out the tumor. But if you have a problem, brain is bulging, there is everything is bleeding there, achieve hemostasis, come out, maybe take out the bone flap. Now, air cells, I talked about it. Now, this is sometimes you may not be able to see it. So you careful, and that you can pre-operatively, if you have a CT bone window, you can find out, you see that air cells there. Sometimes it's not visible on the microscope, but you put the endoscope. This is the intraocular canal, and that's the air cell. So when we find that is small air cell, you put a bone wax. If it's a large air cell, we put fat inside and then put bone wax. And then we put fat, bone wax, and then fat, sandwich technique, and then put some glue there. And that takes care of the risk, reducing the risk of the CSF rhinorrhea, which can be a killer. Now, this is something one sometimes find the vessels stuck to the bone, the ICA stuck to the posterior surface of the petrous bone. And then you cannot decompress you have to release the vessel before you can get into the tumor. It's a little problem, but you can do it. Now you see that vessel, that ICA stuck to the bone posterior margin, and sometimes it goes inside the intraocular canal. And fortunately for this patient, it was just stuck to the dura. So we just cut the dura and release the dura from the bone. And along with that, the vessel can be released. And we cut the dura, release from the bone attachment there. And once you have done that, the vessel is released from the bone attachment there. It's not going into the intraocular canal. We have patients where it has gone to the intraocular canal. Then you need to drill all the way, release the artery before you start decompressing. It's a nuisance, but it has to be done. You can't sacrifice this artery. That's critical. So now we have released that artery, and now you can go and take care of the tumor and the routine wave. Now, this is a semi-sitting position. This is a very low-lying jugular bulb. Now, when you are drilling, it's a disaster. It can be disaster. A patient can die of this. So one has to be very, very quick to take care of it. And now it's a bleeding. Don't take the suction out. Let the blood go away. The air should not go in there. And then quickly put some gel foam there, and then put glue, put patty there, and then come out for some time, go somewhere else. And then the patty has to be removed, and then you put a only diamond drill after that. We have another video where I'm not going to show that because time constraints, but you can do that. You can still have a complete excision. Now we do gamma knife, and many patients are being gamma knifed nowadays, or radiosurgery. They do fail. This is one of our patients, 70 plus, 2.5 centimeter, appropriate case, lot of comorbidities, failed. Lot of post gamma knife symptoms, large cyst, edema, patient symptomatic, you need to operate. So when you operate, the trick is The difficulty is to stay in that plane, that tumor anacnoid plane. Tumor is becoming almost white, avascular, but there is a foam and there's adhesions. Little less adhesion than if the patient had radiation therapy, than if the patient had radiosurgery, little less adhesion, but there are adhesions. So the trick we have found is to leave thin sliver of tumor attached to the nerve or the brain stem so that you have a good outcome, and you can still do a near total excision, of course, intra-aortic canal drilling, and near total excision, and you see this is the post-op, and you still have a grade 1 facial function. And that's possible, but so we need to be prepared for that. So we published that earlier 16 cases, and then recently last year we published in ACTA, and there is this increased predilection of cystic recurrence in this type of tumors. Post-operative, now this is a patient, more recent patient, giant tumor with hemorrhage into the tumor. We operated, patient was all right post-op, but you can see the subarachnoid blood there. We didn't realize the importance of that. The patient was discharged, I think 4th or 5th day, to come back for stitch removal. And the day he came back, with a left hemiparesis and significant hemiparesis. You see the MRI, you can see there is the infarct, and there is this vasospasm, which is not so well described in this literature. Again, fortunately, the patient improved, and the 2-month complete or near complete recovery of the hemiparesis, and this was published in Case Lesson Journal of Neurosurgery. So how am I doing with time, Milind? If I time, I can stop it here.
You have 5 minutes, sir.
Okay, that's very good. So this is not actually, this is a different CP angle tumor, but this is a nice educational video, so I thought I'll show it to you. Did a far lateral approach. We go with a diagnosis of CP angle meningioma. I just wanted to show you, just see that black thing, dark T2, which we did not give too much of importance. The patient didn't have any other problem, so we thought it's a form meningioma, and we went in there, and it was a very firm tumor. And when we were doing that tumor surgery, we were trying to dissect, the vessels were all inside. This was actually metastasis, and the ICA got injured, is cut actually. And so what we did, we put temporary clip. This is a mini temporary vascular clips. And then we, as quickly as possible, we try to remove as much tumor possible so that we can have some space. And we see the nerves are inside, the 11th nerve, cranial nerve is inside. And she had no other symptoms other than this CP angle syndrome. And you see this is a firm tumor, we had to cut it. It was going into the jugular foramen. So once we have done that, we had space, then we stitched that end-to-end anastomosis with 10 of suture. Okay? And then we put some papaver there, and the rest of the tumor, we remove it. This was late in the evening, so we did not have the frozen section. We still was thinking that it's a meningioma, so we wanted to take out as much as possible. And then you see that there is 12th cranial nerve with vertebral artery. This is I just wanted to show the ICG. We did an ICG. I think this will come now, showing that a patency is maintained. The brain is good, lax. Now you see the IC. That is the anastomos, end-to-end anastomos pica artery. The pica, yeah, the pica branch there, which had got cut and which injured, and then the routine things. So the trick is avoid diathermy. If it bleeds, don't panic. Pack it with something. Come back. And then resuture whatever way you can if you have the competency. Now anticipate T12 hypointensity is a firm tumor. Post radiotherapy, redo cases are more likely risk of injury, so you have to be careful and try to restore circulation and post-op angio to see that the patient is all right. Thank you very much for your attention.
Thank you very much, sir. That was a very elaborate and a very precise lecture. Encompassing all the complications that one would encounter in this difficult kind of surgery. So, sir, we will take questions at the end. When is it okay with you?
Yeah, no problem. Absolutely.
Okay. Milind, Abhay, can you introduce the speaker?
Yes, sir. Yeah. First of all, I'd like to thank all the speakers and the panelists who accepted my invitation to be here today. Thank you, sir. Let me invite Dr. I.P. Cherian to deliver his talk. He is the Director of the Neurosciences at the Krishna Institute of Medical Sciences, Karad. So he will be talking on complications in CP angle meningioma prevention and management. Please go ahead, Dr. Cherian. You're on mute, Dr. Cherian.
Thank you, Abhay. And thank you all. It's an honor to be here. So I was thinking, we probably, amongst the younger neurosurgeons, I would have been one of the chaps who's had so many changes with the petroclivals and so many complications. The changes happened because of complications. Each time we try something, and I don't leave anything just because I've had a complication. But then, when you are in your resident stage, you see these petroclival meningiomas being done with 2 extensive approaches and 1-day bone work, 1-day meningioma. And then you're confused as to how you should do it. And then you go ahead and start doing it. And you suddenly realize how difficult it is. And then, you have vessel injuries, you have nerve injuries. And then over time, you understand more and more. And then you come to a scenario where you can start taking things out a little bit more safer. So this is the course of, the charted course for most neurosurgeons. Anybody who either stops with a mistake or claims no mistakes wouldn't have done enough. So any young neurosurgeons, we have masters here. We have Dr. Goyal here, Professor Basant here. So Suresh, I see him here. So all of these giants would agree with me that and in the last 15 years, we've had in a place where we didn't have much facilities to start with. And then later on, we got some facilities, but we realized that petroclival meningiomas, one of the biggest morbidity is the approach. So the approach itself sometimes is a big morbidity. I'm sure the masters here would agree with me. It's a terrible approach. So what we started doing is we started doing smaller and smaller approaches, and we realized that if we center the approach onto the temporal bone, there is a very good chance that we could take out most petroclivals completely. I used to have 6 nerve palsies for some time with this approach, but later on, that also has improved now. So we have learned from many people. So I'd want to show you a small case here. And here I would like some extensive discussion. So starting with the radiology, this is something which we did with the exoscope. So that is why we now shifted to the exoscope. So it's an excellent tool because first of all, you get to have both your hands in the field all the time because your exoscope
Dr.
operation.
Cherian, have you shared your screen? We are not able to see your screen.
Oh, I'm sorry.
Yeah.
Yes. Okay, I'll share my screen. Can you see my screen?
Yeah, now you can see. Yeah.
Yeah. So I was sorry, I was just going on myself. So let us see. Can you see this tumor?
Yes, we can. Yeah. Go ahead.
So this is a cystic solid petroclival meningioma. We thought it was a schwannoma actually, but there are some things which indicate it is a meningioma. But the most important thing here, what we realized, and we've had mistakes, is you can see there's a vessel there. It is the basilar, but more importantly, what is there is a small nubbin from this vessel, and that indicates a perforator. We've had a very similar case where we went ahead. It was not a cystic solid, it was a solid meningioma, where we took out the entire meningioma and the last bit we started pulling out. We pulled, we were very gentle with it. We pulled. There was a little bit of bleeding, and we bipolared it. And then, we developed, the patient developed a brainstem ischemia and a very bad result. So we thought we had done an okay surgery, but then, we had this complication. So we decided that we'll do something, as Professor Basant was saying, that he doesn't go on the other side of the glistening membrane. It's exactly what we do now. What we do is, with the exoscope, you can afford something called total internal decompression, which means you just stay inside the tumor capsule and you can take every bit of the tumor till the arachnoid. Okay. And we've never had any problems with that. In fact, started doing it for CPA angles. We started doing it for every other cases where there is critical structures on the other side. So whenever there's a critical structure, when we are pulling or pushing, when you're trying to take the capsule away from vessels and critical nerve structures, that's when you have problems. So here we'll show you what we did. So we went with the normal small petrocell approach, and with a 4 by 3 centimeter craniotomy, you can go ahead and get the frontal as well as temporal approach. And then you can go ahead and take off the orbitomeningeal band. And then the V3 is what you are dissecting now. That's a V3. And you have the Kawashi's triangle. Actually, it's not a triangle, actually. So that's a GSP in there. And the Petrus edge is being defined right now. It's very important that you do a lumbar puncture if you're not able to open the cisterns, because you will need the brain to be quite lax. You don't want any retraction here. Sorry, I'm having some lightnings or something. Let me just start again. Can you see my picture? Can you see? Hello?
Yes, Dr. Charan, we can see. Yeah.
Yeah,
Go
there
ahead.
was kind of a lightning effect. Yeah, can you see now? Okay. Going ahead now. So you have come to the this region. Now, here is a cystic tumor. Here you don't need to take out you don't need to do extensive bone drilling. So, but we are drilling the medial part of the Kawashi. And you must know where the cochlea is. So you can take out an L shape, So the cochlea is going to be here. So you can take an L shape here. You can decorticate the cochlea, and sometimes I even drill post IAM. I drill post IAM so that you will hear. I'm going to show you just the fifth nerve and the seventh nerve, and we are going to be in the proper petroclival angle. So we are going to be just between the fifth and the seventh. So here I can see the fifth nerve going in there. So, and then I'll go and I'll show you the seventh nerve. That's the IAM, dura. So once you take that, then you open the temporal bone dura and then cut the tent. You have a much better access than you can think of. So here what you've done is you've done a very tailored, very small drilling. And then after that, you open the temporal bone dura, and I'm cutting the temporal bone dura. See, this is the fifth nerve. SPS over the fifth nerve. The superior petrosal sinus always goes above the fifth nerve. So you have to deal with that. Earlier, we used to put Liga clips, but there's no need. Once you cut that, you can extend your cut into the Meckel's cave. And you extend that cut into the Meckel's cave. And then when you cut the tent, the whole thing, that whole dural leaflet can be taken anteriorly, and you get quite a lot of space there. And now we are going towards the medial extent of the tent. So you're defining the tumor now. It is cystic and solid. So the Meckel's cave is opened with that extension of that cut. Now the tumor surface is seen clearly. We go ahead. The tent has to be bipolar. The tent can be sometimes a vascular structure. So we always, and you have to always be on the lookout where the fourth nerve is. You can see the fourth nerve now. You will see the fourth nerve now. Yeah, you can see the fourth nerve there at the edge of the edge, just right side. You can see the fourth nerve. Now here you can see the seventh nerve. That is the seventh nerve. That's the IAM, seventh nerve. Anteriorly is the fifth nerve. So the tumor is right between, you can see posteriorly the seventh nerve and anteriorly you will see the fifth nerve. So I'm going to decompose. So it is right between the fifth and the seventh, and it's a very tailored, minimal resection of the cavase as well. So we are going to open into the cyst. We are going to take out some part of the solid capsule and then going into the cyst. So you can see already this fifth nerve you can see. You can see anteriorly, you can see the fifth nerve. That is the fifth nerve. This is the seventh nerve. So you are right, and you are operating now. You are operating between the fifth and the seventh. True petroclival angle. And you are going on taking out this tumor. In solid petroclival, the fifth is plastered up. So once you open the superior petrosal sinus, you have to go below and take off all the dural attachment. Here there is no, see here I'm taking off every single, you can see the arachnoid, and I'm taking off every bit of tumor with the adjustment of the exoscope and a very, very high zoom, keeping on shaving the tumor with very low setting and keeping on shaving till you see the arachnoid. Sometimes you can break through the arachnoid also. So you are keeping on taking out every bit of tumor. Now see that movement. That is because you have the exoscope on your leg and you can keep on pivoting the exoscope. Now you have to see where the basilar is. So you put in an endoscope holder, a robotic endoscope holder. This is a 10 millimeter endoscope. It's called the Einstein machine. It's a 3D endoscope. So, and after you see that, then you can see that perforator. You see that perforator of the basilar, just like we saw in the scan. So we completely take out all the tumor from internally. So you keep on taking it internally. You look with your endoscope if there is any tumor. If there is any tumor, you take it out. So this is what we wanted to show. And I think I'll stop my talk here and I'll ask Abhay to resume or to go ahead and resume the series.
Yeah. Thank you, Dr. Cherian. So what we'll do is we'll take the questions at the end of the three speakers' talk. Okay, is that okay?
Yeah, absolutely.
Okay, yeah. So Dr. Mujumdar, you want to invite the next speaker?
Yeah, so thank you, IP. That was a great talk and great demonstration. So I would invite Dr. Sandeep Iratwar for his talk on his experience in CP angle surgery. Is Sandeep there?
Yes, sir.
Yeah,
I'll
Sandeep.
just share my screen.
Yeah. So,
Okay. Can you see my screen, sir?
yes. So Sandeep is a professor and head at the Department of Neurosurgery in Wardha. And I'm sure that his experience would be quite enlightening. Go ahead, Sandeep. Thank you.
Yeah. Thank you so much, sir. And thank you, Dr. Abhay Kumar, for this opportunity. It's an honor to share the platform with the masters like Dr. Basant Mishra, sir, Dr. Goyal, sir, Suresh Nair, sir. Compared to all these giants of neurosurgery, I have a very small experience, but whatever I have learned and learned from the mistakes and complication, I would like to share. It's actually Dr. Mishra sir has covered almost everything, but what I have learned from my settings and the the place where I had started working in 2012. So that might help some young neurosurgeons in the group. So as even though I was trained at the very good institution of Amrita Hospital, Cochin, under able guidance of Dr. Dilip Panikar sir, where we had all the facilities to manage all the complicated skull-based tumors. But when I landed up in Wardha, it's a Datta Meghe Institute of Medical Sciences in 2012. So I had patients, I had big tumors like this, but no such great facilities. So the first case I did with ENT microscope, and fortunately I had a good ENT department with the facial nerve monitor and the Manman drill and basic instruments. So I was scared to see such big tumors. How can I remove with the limited instruments available? So I used to do bigger craniotomy even though I was not trained for this. So I thought it can get a more exposure. Because the exposure, I think the tumor resection will be easier. But I was wrong. And even though I could remove the tumor successfully, I could see a lot of complications related to the bony exposure, and particularly the CSF leaks and the post-operative suboccipital headache, which is very common after doing such a big craniotomy. And the CSF leak ultimately leading to meningitis in some patients has really caused mortality, and that was very uh, frustrating in the initial period of career. And then gradually we thought, now we got some better gadgets, so we could, rather than doing craniectomy, I started doing craniotomy, where we can still do the better job. But still, I used to do a bigger craniotomy for such a typical Coues grade 4 tumors, of course, the vestibular schwannoma. But instead of doing good surgery, this approach itself, and the conventional retrosigmoid approach, it's a long incision. We used to do lot of muscular dissection, and there is a potential space which can collect the CSF. As we can see in this particular patient, the post-operatively, even the tumor was removed completely, the patient has developed pseudomeningocele, and as maybe because the craniotomy was bigger and the the dural closure may not be uh, the watertight closure, and there's some dilatation of ventricles, but still this could be avoided. Because what I have learned in the first 5 years of my practice, we don't need such a bigger exposure. The area which is highlighted in this picture shows that's our area of interest, where we are continuously working in that particular direction. And as Dr. Mishra sir has shown the beautiful videos where he used a smaller craniotomy, and where he has shown the linear dural opening, which actually minimizes such complications. And after learning from Professor Charlie Teo, I have also reduced my size of incision, the size of craniotomy, and I have started uh, attempting the watertight dural closure, and which has really reduced my complications significantly. A similar such patient with the Hughes grade 4 vestibular schwannoma, uh, I used to do surgeries in the supine position with the head turned to opposite side, where I support the shoulder so that I don't uh, allow the brachial plexus, or too much of extension would cause brachial plexus paralysis. So that all precautions been taken care, and then you just do the post auricular linear incision, which provides the access to the area where we are targeting. It's uh, uh, basically you have to expose the retrosigmoid and transverse sigmoid junction, and this can be targeted by this, or the line which I follow, the orbito meator line, and also palpate, and you can mark the mastoid tip below, and if we go from behind, if we follow the anion, and if we just draw the landmark of sinus, the sigmoid sinus and the transverse sinus, and if you plant the craniotomy here, and if this incision can expose the 3 by 3 centimeter square shape, and we can do the craniotomy like this. And nowadays I do the square shape craniotomy, which allows more space to introduce my instruments. And once the dura is open, as shown by Professor Mishra sir, once the CSF is released, the tumor is removed, we can close the dura. And this is what we need to do at the first stage. Once the dura is open, you release CSF as much as possible from the cisternum magna, and then retract the cerebellum, and then you try to peel up the arachnoid from the tumor. Just peel up the arachnoid, dissect much, and then, as Professor Nair sir always mentioned about the arachnoid plane and the relation of tumor. So this is what, and once the tumor surface is sure about the facial nerve course, and then we just start debulking the tumor. And of course, we monitor facial nerve for each and every case. Now we have got our own setup. We have got own hand microscope, endoscope, and CUSA navigation. So we try to use almost all the possible gadgets to do this beautiful surgery beautifully. And then we follow all the principles, microneurosurgical principles, to remove this tumor, the CUSA, the decompression, internal tumor decompression, and decompression. And once you feel that you have adequately decompressed, then we mobilize the capsule wall, and then we drill the internal auditory meters, and we use the angled endoscope to deliver the intracanalicular part of the tumor, as shown by Professor Mishra sir. And then the last bit of the tumor is being removed, and this is the final picture after tumor decompression. And this is what I have started doing since 2016, a small craniotomy, which allows me to do tumor resection for Coos grade 4. And I can also preserve the facial nerve. Of course, I cannot preserve the hearing in such patients. And post-operative video shows the normal facial nerve function. And this is the incision which I was mentioning about. You can see there's a small transverse incision without much potential space there, and it doesn't allow any CSF to get collected there. The similar patient, if sometime if you don't get into the cistern magna, still there are some cases where you can see the CSF cleft. There's a CSF cistern which, if you open, can get the space enough to proceed with the surgery. Then we have to follow the normal microneurosurgical principles. And the incision, again, the same linear post-auricular, and of course it could preserve the facial nerve function post-operatively and excellent outcome. This is one of the difficult tumor to remove. I thought this is a cystic tumor. I can just peel off and get away with the tumor, but I was wrong. I have removed this tumor, and the capsule was densely adherent to the brainstem. And this patient come back to me with a recurrence in 3 months. And then I had to go back and remove the tumor, and I had to slowly peel off the capsule wall. And still, this patient had a transient facial paresis and hemiparesis as well, because the capsule was densely adherent to the brainstem. But gradually, within few weeks, patient improved well, and it's been 3 years now. There is no recurrence. This is one of the commonest of course, after vestibular schwannoma, the epidermoid in the CP angle, this young lady presented with a trigeminal neuralgia, which was medically refractory. On evaluation, we found this epidermoid, which is in the CP angle going up to the Michel's cave, and the facial nerve and the vestibular nerve going through the tumor. As we all know that we have to operate such tumors between the nerves. So after microscopic resection, I just put the endoscope to see the tumor extension and the nerve relation of the nerves with the tumor, and you see the facial nerve is so flattened, and because of the nerve handling, I feel this is not the way I should have removed this tumor. We should have been more delicate while handling the facial nerve, because I could remove the tumor completely. The lower cranial nerves were intact, but the facial nerve was bit confused, and this patient, of course, the post-op CT scan was good, but patient developed post-operative the left facial nerve paresis. As the anatomically the facial nerve was intact, but the function was impaired, and but within 2 weeks, this patient's function has improved. She could close the eyes completely. And the trigeminal neuralgia has disappeared completely.
दर्द अभी है जो पहले था ऑपरेशन की जगह दिखाओ.
In this case, I have learned that I could have been more gentle with the facial nerve. And this is another patient, the large epidermoid tumor. Of course, this can be removed with the small craniotomy, but see the size of the tumor, and when I removed it, it was removed totally. But again, the capsule of the epidermoid was densely adherent to the brainstem. This actually led to some stormy course in the post-operative period, because I was a bit more aggressive while removing the capsule of the tumor. I was trying to peel off away from the brainstem. I could remove it completely, but this patient had a hemiparesis for few months and recovered completely. And for in my experience of 13 years, the first 5 years were full of complications. Later 8 years, I have improvised to the extent that I could preserve the facial nerve function in vestibular schwannoma in 84% of cases. And the lower cranial nerves paresis were seen in the few cases in the first 5 years, which has been reduced significantly in the later phase. Surgical site infection, CSF leak has been dramatically reduced. In just one patient had a CSF leak, and no meningitis, no post-operative headache, no pseudomeningocele. No mortality in the later phase, but initially I had mortality, and that was secondary to lower cranial paresis, which need to be that ultimately led to post-operative ventilatory associated pneumonitis and so on. So gradually I have improved. I have learned a lot from these complications, and masters like Atul Goyal sir, Mishra sir, Panikar sir, Nair sir, and I'm hoping to learn more. And thank you so much for patient listening.
Thank you, Sandeep. I think that was a fantastic demonstration of your experience in the last maybe 12 years. And I think that's how it should be, I think, that initially during your career, you have this kind of issues and then you improve upon them. My sincere best wishes to you, Sandeep.
Thank you, sir. Thank you.
So, Abhay, can we go with the panelists?
Yes. Yes, Sandeep, can you unshare your screen? Yeah. Thank you, Sandeep.
Sir.
Thank you. Thank you. Yeah.
I think all the panelists, Dr. Nair, Dr. Rajan Shah, and Dr. Suraj Dugani can give their opinions on all these 3 talks and maybe take it forward. We have about 20 minutes, right?
Yes,
20 minutes
yes, we have 20 to 30 minutes. So let's start with Dr. Suresh Nair, sir.
No, I think I will come last because
Okay.
first Dugani come.
Yes, sir.
Bugari,
Dr. Suresh
Rajan,
Bugari.
and then I will come. Yeah.
Okay,
Thank you.
Suresh, hi.
Thank you. It was yeah. Hi, hello everybody. It
Hi,
was
bye.
a wonderful, wonderful presentation, and congratulations and thanks to all the speakers for excellent presentation, highly academic, and sharing their experiences. I'm sure. See the experiences what they have shared with us. Are all our experiences. Also, what we come across in our work, day-to-day's work, and greatly. See, the wise man is the one who learns from others' mistakes, and today really we learned a lot from all the three speakers. So it was wonderful learning. Few things I thought I'll just ask senior professor Basant Mishra, sir. Can you hear me? I think you have to unmute.
yes, sir, we can hear you.
Yes, yes, I
No,
can
no,
hear.
Basant Mishra.
Yeah,
Yes,
Suresh, I can
yes.
hear you.
Sir,
Go ahead. I had muted.
Yes, yes, thank you. It was excellent, sir. Now, when you start decompressing, expose the lesion and start decompressing the tumor. Now, do you access the superior part of the tumor or middle part of the tumor or inferior part of the tumor?
You mean the initial part?
When you open the capsule,
Yeah.
where do you?
Usually I go in the center of the tumor and
Right.
decompress. Then I come up.
Yes.
There's no fixed, plan. Whichever is, if there is a
Yes.
problem and I'm losing the plane, I go to some other site. But
Right,
usually
right.
in the center of the tumor, I decompress first.
Right. Because why I asked this question, I'm sure all of us.
First, after CSF, like very nice demonstration Sandeep's did after the CSF has to be, kind of released. The brain is lax, and then it decomposes.
Yes. That's it. And sometimes what happens, we have seen this facial nerve because of the situation of the lesion. It goes on the middle part of the tumor, inferior part of tumor, and a few cases we have seen the facial nerve being shifted the superior part of the tumor just below the trigeminal nerve. So I think the growth pattern of the tumor, one needs to understand here how it is growing. It is going superiorly towards the tentorium or going towards the lower part into the CP angle or going posteriorly. Probably we have to imagine.
Suresh, I just want to tell you something.
Yes.
In my practice, I have never had a facial nerve bang posterior to the tumor, right? We have never had this. And it's not mine. I mean, Professor Sami, 5,000 or maybe 10,000 cases now, I don't know. He never had a facial nerve posterior, though there has been reports, and there are some surgeons have reported that they have noted that. But I think more neurofibromatosis patients, they can have that. But in sonomas, the patient with sporadic tumors, I have never had a nerve which is stimulated posterior tumor, never. Because I use the nerve stimulator initially from the beginning. So there's no. But what you said rightly, it can be displaced anteriorly, superiorly, anterior superior, anterior inferior, superior, inferior, all that is possible. So that is why if you have, I mean, I don't think it's mandatory, but if you want, especially the person who is starting his career, young fellow, and now the MRI is available everywhere, and you can use the MR tractography to study the facial nerves disposition to warn you where you have to be more careful, right? So that is what we have, but once, I mean, it's not something which is essential. It's not that we routinely do it, but this was a dissertation one of my residents, and then we found that this is useful. You can use it. We don't do it regularly.
Right. Thank you. Professor Mishra, sir, again, at what stage of the decompression you start decompressing or drilling the internal artery meatus?
Yeah, so we need to decompress till about, say, a few millimeters of the tumor capsule is left, and the brain is lax. You don't have to retract. I put the retractor so that my instrument, my drill, does not touch the cerebellum, but no retraction. You should not retract the cerebellum. If the ones that is reached, whether it is 5-centimeter tumor or 3-centimeter tumor, 6-centimeter tumor, you have to have enough space so that you don't have to retract when you are going to drill. And that's my criteria when I start doing the drilling. For intracanalicular tumor, you don't need to do drilling.
Right. No, again, a very important point already you have addressed. What I thought I'll raise it that high riding jugular bulb. Many times we face this problem and you have addressed it very nicely. A small tip for the younger generation is that when you start seeing the tumor or debulking the tumor, before you start the drilling of the internal artery meatus, you locate the lower cranial nerves, see the lower cranial nerves, where they're entering to the jugular bulb. Is it closer to the internal artery meatus or is it distal to the internal artery? Probably that gives us an idea that this patient has a high riding jugular bulb, and you must avoid drilling at the inferior part of the internal artery meatus, which part you have very nicely covered, sir. Another important issue here for the younger generation to know is a Dandy's vein, where it enters into suprapatellar sinus. I personally feel always let the size of the tumor be anything. It needs to be preserved all the time. And I take all the care to preserve the Dandy's vein. That is my take. I would like to ask the speakers and panelists to opine. Thank you.
Dandy's vein, we never have a problem in acoustics. Dandy's vein is more of a problem in petroclival meningiomas or clival meningioma, Pitras apex meningiomas, even in MBDs. You know, because sometimes it is the big vein and the fifth nerve you're not able to see properly. But like you, I am always very conservative about sacrificing I mean, that's my last resort. And one simple trick, if you want to sacrifice, you can do the ICG and see the flow of the veins. You temporarily occlude the vein and see what's happening. You can keep it occluded with your forceps or put a temporary mini clip and see if there is no problem and the veins still feel. And if you have multiple veins, then it is safer to cut very close to the bone attachment, not on the bone attachment, then it bleeds just about few millimeters off the bone attachment. And sometimes there is a vein which is draining away. So there's some few tricks there, but that's my last resort. I'm acoustic. Actually, I've never had a problem in the Dandy's vein. The problem more is petroclival meningiomas or even trigeminal neuralgia, extensive epidermoids, and so on.
No, the large angles, sometimes we make it that in the large angles.
Suresh,
thank you very much.
Can I make one point here about
Please,
Dandy's vein? See, Dandy's vein, we seldom need to cut the Dandy's vein. But you know what? If we are doing the operation in a sitting position, and sitting position is very commonly done, and I like sitting position. And during sitting position, if you have a problem of venous bleeding from the Dandy's vein, and you try to avoid it, or you try to preserve it, or you try to maneuver the vein at that point of time for a period of time, there can be a very high risk of venous air embolism. So I think if we have to preserve it, we can preserve it, we should preserve it. But if there is some bleeding from the dome of the tumor in the region of Dandy's vein, then we have to rapidly get done with it so that you prevent air embolism. This is my very firm feeling about this vein.
Thank you. I agree with you, sir. Thank you. Professor Nair.
No, I will come after. Rajan can come.
Dr. Rajan Shah, sir, your initial comments, sir.
No, in fact, all the lectures have been quite fantastically delivered. Basically, I had the same problem what Suresh was trying to say, because sometimes just drainage of the CSF starts the bleeding on the superior surface of the cerebellum. So that is one place where I would like to have some comments about how to avoid that, especially in microvascular decompression. I've had on 2 occasions where just drainage of the CSF, and before you can really enter the CP angle, there is a bleed from the superior part, that superior petrosal vein and things like that. So that's where some comments from the speakers will help.
Ajay, can I just comment on that?
Yeah, please.
That's very true. In fact, that's I said, MVD is the petrosal vein creates more problem in MVD rather than in acoustic, in my practice at least. You're right. The moment you start and it starts bleeding, and if you, like Atul said, if you are semi-sitting position, that can be disastrous. One of the small tricks, I mean, sacrificing the vein. What I do sometimes is you take a dry, about half a centimeter square gel foam, put some glue, and see all my CP angle, all skull base, always I have a glue. I have glue already prepared for whatever glue you want to use, it's prepared. So put a little bit of glue on a gel foam, which is half centimeter cube or half centimeter square, and put it on that area and leave a patty over that. These stops bleeding. All the venous bleeding will stop unless it's completely severed. But the sinus bleeding, the petrosal vein bleeding is very common. What you are saying is absolutely right. It's very, very common. It's very irritating because you don't want that bleed to be there. And especially MVD, you want a very neat and clean, and you want to come out, very nicely. So you don't want to see that blood, but that has helped me a lot. I would definitely tell the young neurosurgeons, try that.
Well, fortunately, I've also not lost a patient in that, but it's quite irritating, and at times it's so, your whole concentration is there rather than
absolutely.
The other thing I just wanted a comment, which, like as you said, as Dr. Basant Mishra said, that you back out if there's a lot of edema. So I had one experience, which was a very funny experience. I, in fact, sometimes put lumbar drains in a large acoustic. And after doing that also, when I opened it, the cerebellum was swollen. And I tried for about half an hour, tried to go to the cisterna magna, open it up, but still couldn't do it. And then ultimately I backed off. And, at the end of it, when we were reversing, we realized the urinary catheter was blocked.
Pressure was going.
Very
that's
situation.
Right. That's right.
So that's what has happened. And I hope youngsters can learn from this, because that's something which we realized after we closed and when the patient was reversed. So 48 hours later, we went again and removed the tumor. But a simple thing like this, which we didn't realize, none of us would point out, and that's what happened to us.
Okay, now can I come?
Yeah, please.
Yep, please.
Okay, so counter comments after I finish. I may take 5 to 10 minutes. So what an excellent evening we had. We had always the masterly lecture. I learned everything from Mishra only. What a lovely lecture. And I have to have some critical comments about his lecture. And same, I and Sandeep, lovely lectures. Now, before I start my comments, my thing, I have also never found a seventh nerve posterior to the tumor in all my experience with vestibular schwannoma. And about this petrosal vein, which we discussed just now, and Mishra also told, I have sacrificed for so many tumors. And there are literature also I have seen 80 to 90% nothing happens. Some 5% unfortunate people, they land in problem. And Mishra has also told also, if you want to say, there have been big surgeons like Heroes, Sami, they always tell you sacrifice. But there are counter people who are telling you should not sacrifice. But trick Mishra has told that you put a temporary clip and then not only do ICG to see collaterals, but also do evoke potential, brainstem evoke potential. If there is a drop in potential, there is some problem. Also, some literature, I have written an article for Kasper's book on one of the complications I had, where somebody has written, I think from China and somebody from US, the size of the petrosal vein matters. If it is more than 2 millimeter in size, one should try not to sacrifice it at all. Some people have written 1.3 millimeter is that size. I have never seen, I don't know. Now I'll go to the comments of the thing. And Mishra's thing, what a great lecture, Mishra, always. And I will, first I have to tell, I also, please, you are supposed to talk on CP angle meningioma. First, I have to tell, meningioma is an extra arachnoid surgery. And acoustic schwannoma, vestibular schwannoma is an intra-arachnoid surgery. It is occurring in acousticofacial cistern. This cistern is separated from trigeminal nerve by arachnoid. This is separated from the lower cranial nerves by arachnoid. So you are working in the acousticofacial cistern most of the time because it arises inside the canal. behaves epiarachnoid for some time to become subarachnoid again. So Mishra has told also, he told in between tumor arachnoid plane is good for fifth nerve. Tumor arachnoid plane is good for lower cranial nerve. Here it is tumor glistening membrane plane. What is that glistening membrane? Glistening membrane is the perineurium of the vestibular nerve, or what you can call the capsule, thin capsule, thinned out perineurium of the vestibular nerve from which this tumor has arisen. So facial nerve is stuck to this this perineurium. That is why many people, they do subperineural surgery. Mr. clearly showed some beautiful videos of subperineural surgery. But if you want to be aggressive, you can remove that perineurium also. Vestibular schwannoma, it is like glioma, maximal safe resection. It is not cure. But you should try to remove maximum means leave something attached to facial nerve if it is not coming, or to the brainstem. It is not subtotal removal or anything. Try to remove maximum as possible. And also, there is no harm, no shame to back out. Vishnu told very clearly, you back out when you think you cannot proceed. So one thing is, these tumors arise in another system. There are posterior fossa, CP angle area has got multiple systems. Acousticofacial system, with this tumor arises, trigeminal system, trigeminal schwannoma arises, and lower cranial nerve arises in cerebellomedullary system. So tumor arising from cerebellomedullary system, it has always arachnoid which separated from the 7th, 8th nerve. Tumor arising from trigeminal area system, that always there is a arachnoid which separated from the 7th, 8th nerve, but not for a tumor which is arising in acousticofacial system. Tumor is stuck to the tumor. 7th nerve is stuck to the tumor capsule, and people have, Mishra has told very clearly how to identify 7th nerve, various monitoring techniques. So that is a lovely discussion on that. Other thing what I want to tell is, Mishra told about vasospasm in a single case. After with the patient developed infarct hemiparesis, it is very rare. I have not seen, but of course I have seen it for pituitary tumor, craniopharyngioma and all, but not for vestibular schwannoma. He also told about his dissertation work and all, about intraoperative fluorescent guided dissection. Here the thing is, the tumor fluoresces, the nerves they don't. So now these days, you see, just I read literature because I knew that Mishra will be talking on this. So the general GE people have come out with myelin targeting some dye, which will enhance the nerve. I think it is coming. So after that, one can see the nerves as well. And also he talked about tractography, and the student had dissertation, and I have read literature also. High resolution tractography can find out the position of 7th, 8th nerve, 5th nerve, but not lower cranial nerve. That is the third part of high resolution MO tractography. Now, let me go to the lecture of IPE. I thought IPE is talking on petroclival, CP angle meningioma. CP angle meningioma are meningiomas which are arising posterior to the porus. And he told a cystic meningioma, which is extremely rare. Cystic meningioma is extremely rare, but he showed that cystic meningioma and with the vessel adherent there. And then he passed a comment like that glistening membrane. Here you don't, meningioma is the extra arachnoid. Always there is arachnoid, which separates you from the cranial nerves vessel. Acoustic schwannoma is a subarachnoid tumor. Everything is stuck to the tumor. You have to do patient dissection. Otherwise, you lose it. And and he also showed a petroclival meningioma, which he operated through middle fossa root, and nicely demonstrated how to sacrifice the superior petrocell sinus and then cut the porus and take out the tumor. And nice demonstration of that. And Sandeep, congratulations for your 14-year experience at Nagpur. Nice to know you have reduced your craniotomy to square flap, transverse incision, and also very nice to hear that your complication rates have come down, lower cranial nerves from 10 to 2. this is just for youngsters and all. Large tumors, sometimes you have to handle these nerves. And people may have post-operatively, they have some lower cranial nerve dysfunction. I went for a meeting 2017 to Los Angeles. That was for Yasser Gill's farewell, where the ultimate passing message he gave: if your CP angle surgery or vestibular surgery or petroclival surgery, if your patient has got any lower cranial nerve dysfunction, don't hesitate to do a upfront tracheostomy. Don't wait till the lung becomes white. So you should do a upfront tracheostomy. Post-op headache, I think Sandeep told 12 to 0. Many a time they get headache from this incision. All the incisions, Lacey's, O2, reverse, curvilinear, everything I will cut lesser and occipital, greater and lesser occipital nerve. They cut the nerve. So they have some form of headache. Only incision is a C-shaped incision you make very close to the retroauricular, very close to the ear canal, which can avoid these nerves. But otherwise, this is part and parcel. Headache, CSF leak, both Mishra and Sandeep has told. And also facial nerve preservation. I should congratulate Sandeep for large vestibular schwannomas preservation rate. For large giant tumors, 50% literature says. 50% only large tumors, giant tumors. Your facial nerve function is around 50-60% only. You have a tremendous 84%. And congratulations, I think you all the three speakers covered it very well. Congratulations and learning. Now counter comments, please. Mr. Any comments?
Yeah, I just want to, I understand you have quoted many times the studies about there's no arachnoid, that is a glistening membrane and perineurium and so on. See, as far as I'm concerned, I'm not interested in that. What I'm interested is between a membrane and the tumor, because nothing is written there. Obviously, if somebody has done a pathological study and shown it's perineurium, that's fine. And I think it's wrong to say that you have to go subarachnoid. No, I don't agree with that. Hundreds of times we can stay. So what happens even if it is a perineurium, what happens? The arachnoid gets adherent to the tumor. Okay, so even if it is intra-arachnoid, what you're saying, by the time the tumor comes to us, it is extra. I will not, if it's a small tumor, I will not open any subarachnoid. You will not even see the CSF when I have removed the tumor, especially if it is a small or medium-sized tumor or intracanalular tumor or a tumor. I don't even see the CSF at all. So I think that's a wrong concept that it is a intra-arachnoid surgery. No, I don't agree with that. It's
no, I agree. My comment.
Let me finish. Yeah. It's an extra arachnoid, and there are double layers of arachnoid. So the moment the tumor starts growing, there is adhesion between different layers of arachnoid. So the subarachnoid space remains outside the tumor all the time. So if you remain outside that glistening membrane, all the normal structures are in the subarachnoid space. For all practical purposes, all benign tumors, as far as I am concerned, are extra-arachnoid. All benign tumors. The acoustic, the meningioma, the craniopharyngioma, pituitary, of course, is extradural. That's a different thing. But otherwise, all of these are extra. My dissection is always extra-arachnoid.
Agreed. Now,
outside the arachnoid, glistening membrane, you save all the normal structures.
Agreed. That the glistening membrane is what I am talking. Glistening membrane is epineurium. Now, listen, if you come from the trigeminal side, you have the one arachnoid of the trigeminal system. You have maybe two arachnoid of the facial acoustic system. So you get multiple layers of arachnoid. Doesn't mean that your tumor is extra arachnoid. That bulk of the tumor is in the subarachnoid space only. Bulk of the tumor. Had it been epiarachnoid, you remove the tumor, you should demonstrate a layer of arachnoid over the brainstem. You should demonstrate a layer of arachnoid over the 7th, 8th nerve. If you hardly ever see, never ever see, if it is an extra arachnoid tumor like Mishra is telling, you take the tumor out, like from inside, there should be a layer of arachnoid covering the brainstem. Always there is arachnoid, if you are careful, we separate it from the lower cranial nerves and 5th nerve. Now, arachnoid and your that glistening membrane, perineurium, how to distinguish? That can also be distinguished. It's a epineurium always has blood vessels over that. Arachnoid won't have a blood vessel in that. So if you have a vessels over that, you can tell, hey, this is a epineurium. If it is arachnoid, you can tell it is arachnoid. Got it? That is the way you distinguish. Okay.
Dr. Mishra, there is one question for you from Dr. Ranjit Deshmukh. What are the settings for facial nerve stimulation in the canal or on the brainstem and on the capsule?
Sorry, what is the question again?
The questions are, what are your settings for facial nerve stimulation
Okay.
in the canal, on the brainstem,
I
and
mean,
on the capsule?
I don't know the machine what he's using, but I have the NIMS, NIMS 3, and this is 0.08. We use 0.08, it's very low.
It's uniform all over in the canal, on the
all over the unit. I mean, no, what happens is as you grow, as you go throughout the surgery, at the end of the surgery, your 0.8 may not stimulate it. So you need to go up a little, but the more you go, the higher risk of having a functional deficit, which you will recover, but patient will have the problem. So if you can, at the end of surgery, if you are stimulating the nerve at 0.08, then your function is very good. If you have gone beyond 0.2, then it's a problem. This is what I have found.
I wish to, Mujumdar, just I want to introduce the issue, which is the most frequently discussed and most important issue for a neurosurgeon when he's going to operate on an acoustic. The issue of complete or radical resection of the tumor. That is the issue. You see, when due to my situation in KEM hospital, we have operated so many acoustics. We have grown up from acoustic. We have learned neurosurgery from operating on acoustics. We have learned tumor dissection, tumor resection, hemostasis, arachnoid dissection, facial nerve dissection, eighth nerve dissection. All these dissections we learned from acoustics. In the earlier phase of my own career, I used to demonstrate on several occasions, see, this is my facial nerve, this is my eighth nerve, this is my this nerve, on several occasions. And many of you have seen me demonstrating these nerves and the technique of dissection and technique of cutting the arachnoid, technique of peeling of the tumor and things like that. But over the years, I have realized that in large tumors, particularly when it is more than 3 centimeter or more than 2.5 centimeter, peeling of the facial nerve from the tumor capsule, I think it is quite a dangerous procedure. I'm not saying don't do it. Many occasions you can actually do a beautiful dissection like we have done it and we have shown it on several occasions. But when you need to dissect the facial nerve of the capsule for a prolonged period of time, say you're continuously dissecting for 15 minutes, 20 minutes, I think that dissection has to be avoided because that is almost always associated with a very, very bad facial nerve palsy. This or weakness in a number of patients. No, I'm not saying in all patients. In large tumors, which are more than 3 centimeters or 3.5 centimeter, my current attitude is that I don't even try to identify the facial nerve. I leave a relatively significant sheet of, I'm not saying, if you are, going to do partial resection or subtotal resection, you will end up leaving a lot of tumor. A sheet of tumor, which the whole thing you can move along with the facial nerve. I think my current strategy is to be conservative on the facial nerve. Don't try to tease out the facial nerve. In large tumors, such teasing is quite dangerous for the face, and that can lead to a very disastrous complication for the patient. This is my current feeling on the facial nerve and the extent of tumor resection. Of course, I like to do dissection. I want to do dissection, but my teasing off from the facial nerve has currently reduced over the period of time.
Yes, sir. Sir, do you remember that we had once that facial nerve on the posterior side of the tumor? If you remember way back early 2000, when there was no monitoring, it was a young patient who was actually known to some of us. And you, I remember that this thing, I was assisting you for that acoustic. And I think you took the incision on the capsule and you screamed that, oh, that was the facial nerve probably. And we had not realized that. I remember it distinctly. Maybe we had that one case where there was facial nerve on the posterior aspect of the tumor.
See, facial nerve,
Mazinda.
just a minute, Suresh.
Yeah.
Facial nerve, in cystic tumors in particular, where the cyst develops, and as even Suresh Dugani was mentioning as how the tumor grows and where the tumor grows. In cystic tumors in particular, the location of the seventh nerve can be quite variable. And, in cystic tumors, the facial nerve can be quite flattened along the significant part of the dome of the tumor. In cystic tumors, particularly to tease off the facial nerve from the dome is rather dangerous, and I will completely avoid it today.
Yes. I think we have closing comments from.
Mazinda, just one more thing. That
Yes.
Mishra correctly told, very rarely, schwannomatosis patients usually they don't develop vestibular schwannoma. Case reports are there. But NF2 patients rarely can have a posterior displaced seventh nerve. But if you get a seventh nerve posteriorly, suspect cochlear schwannoma. It's very, very rare. You should suspect it is not arising from vestibular nerve. It is
Vestibular.
arising from cochlear nerve.
So maybe
Okay,
that
very
was a
nice.
cochlear schwannoma.
Yeah.
I think we are almost done. So
Just,
I think any other.
Mujumdar, I just want to make
Can
a
I have a,
Yes,
can I have
sir.
a last
Yes, sir.
question, please?
Yes,
Yeah,
yes.
go ahead with the question
Yeah,
before.
yes, Ranjit.
So I have seen recently that many people are just debulking the tumor, say even 3 centimeter or moderate size, large tumor or even small tumor, and then sending for radiosurgery. I still follow what Dr. Mishra, Dr. Goyal, Dr. Apte has taught me to try and take out as much as possible and just leave a sliver on the capsule. So is it recommended officially, or are there papers who say that by
No, it's not nothing official about it, but there is a group of people who are recommending, including one of our good friends, a neurosurgeon from India who is now settled in Switzerland. So there are people, Americans, who are recommending that what you're saying, the subtotal excision go for gamma knife or go for radiosurgery, right? But I don't think, see, I just analyzed till 2023, some 1,000 odd cases which I have operated, of which 170 cases had gone on to receive radiosurgery, right? So it's 17%. Initially, it was about 10 years back, it was 10%. But like Atul said, one becomes conservative over a period of time. So one is more cautious about the facial nerve function. And that's correct. I mean, it's a disaster. But having said that, many of these patients, if you have the monitor, you can remove the tumor of the nerve, and they will develop a little bit of facial paresis. But most of them, by 3 months, 6
acceptable?
months, they come back normal. So, and while my very good friends Atul and Suresh say that this is not a cure, I think it's a cure. If you can remove that tumor, it's a cure. Not like meningioma. Meningioma is not a cure. Meningioma is meningioma for life. I mean, the longer you follow, the more the patients will recover. Probably most of them, you follow probably 50 years, everybody will come back, even if it is a grade 1 meningioma, but not acoustic, not acoustic. See, not all acoustics, no. If you have removed the tumor, they will not recur. Not everybody.
Mr. I agree. Mr. I never told, I tell the recent trends. They are going away from cure. I am also for cure only. But now, Ranjit, your thing I will tell. It's a subtotal removal and upfront gamma knife. That is what you wanted to know. Say 30% of the patients you remove subtotal, they can grow. Not all the subtotals will grow. So the better step will be you follow them up. If this subtotal people, the tumor is growing, then send for gamma knife. Not upfront. That is I don't know, it is a backward step. That is my view.
No, I agree.
So my concern is in younger patients, if you operate and give gamma knife, still the tumor is most of the time there, and you have to follow up, you have to do repeated scans, and sometimes they have to give re-radiation.
There is no rush about doing radiosurgery.
Long
There is
period,
no
like
rush.
10, 20, 25 years, what happens to these patients where substantial tumor is left? Like from 3.5, you come down to 2 centimeter, give gamma knife. So what happens over 10 or 15 years time?
No, Ranjit, see, there is a lot of data which suggests there is a good protection. There is no question about it. But you are giving another modality of treatment, which is radiation. You see, radiation has its own side effect. There is cystic formation.
Yeah.
I just showed you that we published that 25 cases. Now we have 26 cases. And these are much more difficult to operate. That is one. And though it is, there is no convincing evidence, but there is the risk of malignancy. See, you can't wish it away. So you can't just do radiosurgery for everything. Like Suresh said, many of these patients don't need it. And very large number of patients, we have some enhancing component. You just follow it up.
So I follow it. If it is a small component, I usually follow it for long period. And rarely they go. I agree.
Ranjit, the problem which I think the CMC group have published it, Rajsekhar has published it. The problem in our country is they don't follow up. They go away and they come back with a giant tumor again. That's the problem. That is our problem. So that is why.
I will say, Ranjit, I will say to you, you are saying I leave small tumor if it is without radiosurgery. I will say, even if it is large, what is the harm in leaving the tumor if you can do a good follow-up, like what Basant is saying? If your follow-up is okay, and if it recurs quite large, you come again and operate and again leave a little bit of a tumor, a little largish tumor. You see, I've got several patients in my series which have never needed operation. And other thing, Basant, I wish you can read my paper. I know you may not have time to read my papers, but you read my beautiful article. Once an acoustic, always an acoustic. I wish.
I've heard that, Atul. I have heard that. That's why I contested that. I don't agree with that. I don't agree with that. Meningioma, yes. Meningioma, yes. Not acoustic.
Basant, you have heard it, but you have not read it. I'm saying you please read it, and you will enjoy it. May not.
Sir, I think we have to. It's already 10:05. We have time. I thank all the speakers and the panelists and the participants. I think it has been a fantastic discussion. And when there are masters, there will be more discussion on this. We would love to have this, but in constraint of time, I think we should end this topic. And back to Abhay. Abhay, can you?
Yeah, we have finished the session. Dr. Sarang, do you have anything to say?
No, sir.
No? Yeah. Thank you, everyone. Good night. Bye.
Thank you.
Thanks a lot.
Thank you.
Good night, everyone.
Thank you.
Thank you so much. Good night.
Bye. See you in Istanbul. Okay.
Okay.
Okay, sir.